Hello, students. So, today we'll be discussing the Elite Module 1 question and answer. So, I'll be discussing 25 questions in the Module 1. So, there will be 25 questions basically from the Harrison. It's a Harrison-based discussion. So as you know, Harrison initial phase will contain anemia, iron deficiencies, all those things. So the topics involved is already, the list has already been discussed. So moving on without much delay. So question number 1 is basically based on the iron metabolism. Okay, so the question is like this: how much percentage of iron normally passing through the plasma transferrin pool is recycled from the senescent red cells? Okay, so this is a either you know it or not. Okay, so there is no basically guessworks involved. So directly to the discussion. So basically about 80% of the iron passing through the transferrin pool. So transferrin we all know it is the transfer protein for the iron. Okay. So from the erythroid marrow, the circulating erythrocytes into the reticuloendothelial cells. So this production, circulation, and destruction in the reticuloendothelial cells. So transferrin is the major vehicle of this iron. Okay. So from that, there is a hepcidin mediated regulation and all. Okay. So basically, the basic metabolism, 80% of the iron passing through transferrin pool is recycled. Okay. So absorption usually 1 milligram per day. So from the diet in males and 1.4 milligram per day in women is required to maintain a normal kind of a hemostasis. So the normal transferrin saturation is somewhere between 20 to 50%, 20 to 60%, and erythropoiesis if not increased. Okay. And we all know the transferrin saturation decreases in iron deficiency anemias. Okay. And if there is any increased requirement like a blood loss or dietary iron deficiency or inadequate absorption, up to 40 milligram of iron can be mobilized from his stores. So here the answer is D, 80%. Okay. So second question again about the iron deficiency or iron related erythropoiesis. So this is again taken from a chart. So students, what you have to remember is Harrison tables and charts. So they will ask questions straight from the charts or from the tables. Okay. So you should be thorough with at least you should be glancing through the tables and charts. So in doctor tutorials, we have the Harrison table and chart discussion only by most of the faculties. Okay. So the most of the faculties has been discussing only the tables and chart of the relevant important specialty. So you should go through that. Okay. So question number 2, all are true about iron deficient erythropoiesis except, okay, so serum iron less than 50. And so iron deficiency erythropoiesis from the iron profile, how do you interpret? Okay. So serum iron less than 50, saturation less than 20. Okay. And sideroblast less than 10, protoporphyrin less than 100. So this is the chart. So iron deficiency erythropoiesis. So this is comparison between the normal erythropoiesis, the negative iron balance, and iron deficiency anemia. So there is something in between that is called a iron deficient erythropoiesis. Okay. So as we all know, all these have ferritin less than 15. TIBC will be elevated in all. Okay. Iron, as we can see, negative iron balance. It is serum iron is normal, but ferritin is less. And both the other conditions, iron is less. Saturation again less. Marrow sideroblast again less. RBC protoporphyrin, here it is more than 100. So iron bind to protoporphyrin is like heme, right? So more than 100 in iron deficiency erythropoiesis. When it comes to iron deficiency, more than 200. So and again in the smear, when you get iron deficiency anemia, you get the morphological changes of microcytic hyperchromic RBCs. So here it is not less than 100, it is more than 100. So it is a wrong statement. Okay. And moving on to the third question, again a related topic, very important topic, anemia of chronic inflammation. and false statement. Okay. So interleukin 1. So this anemia of chronic inflammation is basically otherwise anemia of chronic disease. Basically in CKD or other chronic infections, there is a anemia which is more related to iron or iron trapping inside the reticuloendothelial cells. Okay, so interleukin 1 directly decreases EPO production. Interleukin 1 acting through axillary cells release interferon gamma. So basically they're talking about interferons and interleukins. TNF alpha acting through the interferon beta by bone marrow stem cell also suppresses the response to erythropoietin. And hepcidin, they say that's a protein made from the liver, is decreased in the inflammation via an interleukin 6 mediated pathway. So the answer here is D. So hepcidin, we all know it is a negative regulator of iron. It is increased in the inflammation. So it is not decreased. So answer would be D. So basically, it is an IL-6 mediated pathway. It suppresses the iron absorption and iron releases from the storage side. So that is iron is locked inside, and there is a decreased response to erythropoietin also. So what we do in CKD is already the erythropoietin levels are low because of the kidney failure, because of the erythropoietin comes from the kidneys, and there is a decreased response to erythropoietin. You can give doses of erythropoietin to stimulate that. Okay. So, and again in inflammation state, again, like rheumatoid arthritis, neoplasms, basic infections, all these are the same thing again. Okay. So here the answer is D. So question number 4 regarding oral iron therapy, which is the wrong statement. Okay. So this question, when you frame it, it is very important whether you see wrong versus false, exclusion, right statement. So you should get the question right. Okay. Response to iron therapy varies depending upon the EPO stimulus and the rate of absorption. Okay. Typically, the reticulocyte should begin within the 1 to 2 days after initiation of oral iron therapy. Peak response 1 to 1.5 weeks. Absence of response may be due to poor absorption, non-compliance, and a confounded diagnosis. So here that they are asking about the timelines of iron therapy and the response to an iron therapy. Okay. So here response to iron therapy varies because if you have the differential EPO stimulation or rate of absorption or coexisting other deficiencies like B12 or folate, the response varies. In adding to this is compliance to the therapy. So if you are giving iron and if he or he is not taking the oral iron because of the non-compliance, they might have nausea, vomiting, loose stools, diarrhea, etc. So that all has to be accounted. That all has to be taken into consideration if there is inadequate iron response to iron therapy. Okay. So reticulocyte count begin to increase within 7 days after initiation of therapy and peak at 1 to 1.5 weeks. Okay, and absence of a response may be due to other non-compliance, etc. So here it is not 1 to 2 days, it is 4 to 7 days. Okay, so this is the wrong statement. Coming to again question number 5, it is again an iron tolerance. So what is iron tolerance? So false statement about iron tolerance. Iron tolerance to determine the patient ability to absorb iron. 2 iron tablets are given in empty stomach and the serum iron is measured serially over subsequent 2 to 3 hours. Normal absorption will result in a normal response is increase in serum iron at least 10 microgram per deciliter. If iron deficiency persists despite adequate treatment, it may be necessary to switch to parenteral iron therapy. So what is the false statement? So here, determine the patient ability to absorb the iron tolerance test. 2 iron tablets, again, as we said, normal absorption with an increase in the iron, at least 100 microgram per. It's not 10, it is 100. So this fourth statement is also correct. So inadequate response, it's not responding to oral iron, we have to switch into IV or parenteral. There are various other sucrose, ferrocarboxymaltose, isomaltose, etc. So moving on to a different topic, very important topic, sickle cell anemia. So wrong statement about the acute chest syndrome. Okay, so this is a pneumonia-like illness. Second most frequent acute sickle-related event, more than 50% of patients occurring at least once. Chest pain, cough, fever, hypoxia, and a pulmonary infiltrate in the chest X-ray are major diagnostic criteria. Etiology includes in situ thrombosis, embolia, or any type of infection post-operative hypoventilation. Thrombocytosis, leukocyte count, in excess of 20,000. Leukocytosis, thrombocytosis, rapidly developing anemia. So CBC will show you anemia, what kind of a TC and platelets. Potent, severe acute, potent, severe prodrome with possibility of ARDs and multi-organ failure. So what is the wrong statement? So here the answer is because so we all know acute chest syndrome is a pneumonia like illness, second most frequent acute chest crisis event. More than 50% of the patients, it occurs more than one time. Can be mild, especially in children. It might follow as stress like a viral infection or dehydration, etc. And multiple lobes of lungs may be involved with hypoxia, organ failure, etc., and even mortality. Chest pain, cough, fever, hypoxia, pulmonary infiltrate on X-ray. It might mimic a pneumonia. That's what they're saying. And etiology includes in situ that sickled cells can cause thrombosis and it can cause emboli or it can cause hypohydration. Okay. So how do you treat? So basically antibiotics to cover infections, supplemental oxygen that you should maintain adequate oxygenation. Overhydration and excessive opioids can worsen the dyspnea and hypoxia, and red cell exchange. So if it is, let us say 7 hemoglobin, what you do, you don't exchange, just transfuse so that it will dilute the cells. Or if there is a adequate hemoglobin 10 or above, then you don't transfuse because it increases the viscosity. So what you do is you exchange, remove blood and replace it with normal blood so that the dilution happens. Okay, and thrombocytopenia, leukocytosis, and anemia. Okay, so the question had a thrombocytosis. So it is to, you can easily mislead you. So this is the wrong answer. So again, sickle cell, another scenario, leg ulcers, wrong statement. So incidence is highly dependent on geographical and HB genotype, far more common in HBSC disease and HBS beta thalassemia than in sickle cell anemia, HBS beta thalassemia. Tropical and subtropical areas have an incidence rate of 75%. Wet to dry dressing and boots are reasonable initially. Leg ulcers, so it can happen in sickle cell. It can be worsened with what you treat for sickle cell. That is, hydroxyurea can also lead to sickle cell ulcers. Okay, so not the medial ulcers in sickle, leg ulcers in sickle cell disease. Okay, so it is true that it is highly dependent on the geography and HB genotype, less common in HBSC disease and HADS beta thalassemia than in sickle cell anemia. The temperate climates, 10 to 2% patients are affected, and subtropical areas have 75%, maybe due to the climatic change that temperature may affect. And there can be small, superficial, and deep, and encompasses mostly lower leg. Long-standing recurrent ulcers can be difficult to treat, but to dry vision are reasonable choices. So here, less common in HBSC disease. Okay, so answer is B. Voxelotor. Okay, it's a true statement. So basically, it is a drug used in sickle cell anemia. It increases the affinity hemoglobin molecule for oxygen. 1,500 milligram daily was associated 1 gram rise in hemoglobin. With prediction by in all this provided information. So it all seems to be true. Okay, so it is a molecule which increases the affinity of the HP molecule for O2. 1500 is the daily dose. Then Hello. Yeah, I think I'm audible. Okay. We continue. Sorry for the technical glitch here. Okay. So basically, voxelotor. So voxelotor is something a drug which is used in the sickle cell to increase the oxygen, hemoglobin oxygen affinity in all erythrocytes. Okay. So there will be less hemolysis, reduces the propensity of stroke, nephropathy, pulmonary hypertension, leg ulcers, and priapism. So all the above are right. Okay. So moving on to the question number 9. So again, false statement regarding complication sickle cell anemia. So these are all taken from the charts or tables in the Harrison, as I said before. So I would, even in the last moment of your this revision, so you have to go through the Harrison table and chart dedicated revision by the faculties in every main specialties, which will give you a crisp overview of the high yielding questions. Okay, so option A is gallstone in 40% and were related to the polymorphism in UGT1A. More than 80% of patients have hepatomegaly, stroke and saline infection early childhood up to 50%. Acute anemia episode secondary to B19 infection, parvo B19 infection, and folic acid deficiency, splenic sequestration, and delayed transfusion. So you can see this stroke and cell infection, not 50%, it is 10 to 15% of all cases, right? So again, this chart will give you an overall incidence of the complications of each and every complications and a few descriptive of this, because this is, I can't go detail about this is a module discussion. So this you have to revise. Okay, hepato disease, nephropathy, pulmonary, retinopathy, anemic episodes, okay, B19 infection, folic acid, and splenic sequestration. So this question is basically I framed to make you go through the tables of Harrison. Okay, so answer is C. It is 10 to 15%, not 50%. Okay. So again, favorite questions will be from HPLC or HB fraction, HB electrophoresis. Okay. Combinations representing the non-transfusion dependent beta thalassemia, that is thalassemia intermedia, right? So HbA, so they can give you a percentage or they can even give you a figure showing the graph showing the various percentage you have to interpret. HbA, HbF, HbA2. The combinations of these three has been given. So normal, as we also, so from these we have to interpret which is non-transfusion dependent thalassemia. Okay, so this chart again, the HbA reaction. So here we can have an overview of beta thalassemia trait, thalassemia intermedia, thalassemia major, HB beta thalassemia, gamma delta beta thalassemia, and HB Lepore, and gene depletion, hereditary persistence of fetal hemoglobin. So what we have in a beta thalassemia trait is HbA2 more than 3.5 or more 4 to 6. Okay. And here non-transfusion dependent this thing is HbF 10 to 40 and HbA2 4 to 6. Okay, so there will be more of HbF. Beta thalassemia major, it is majority HbF and HbA2 between 2 to 5. HbE, again HbF 30 to 50, HbE fraction 50 to 70 percentage. Okay, and in delta beta there will be HbF. So there is, they have given the various combination of HbA, HbF, HbA2. Further delineation you have to read through, because the they might ask beyond this thing which of the co-migration of the HB fractions, because it's a large topic which cannot be covered in this. It may not be covered in this review. Okay, so here thalassemia intermedia, HbF 10 to 40, HbA2 4 to 6, and HbA 6 to 90. Again, this is a so kind of a memorizing question. Alpha thalassemia with myelodysplasia, ATMDS, wrong statement. So it is alpha this phenotype, alpha 4 phenotype, and mutations in ATRX, striking female predominance, hematological findings of HBH disease. So again, a different chart. So I'm basically taking you through the charts in the Harrison, or tables in the Harrison, sorry. So alpha thalassemia trait. So you have to go through the various this thing. Here we have specifically asked for the alpha thalassemia with the myelodysplasia. So mutations there is in the ATRX, and it is a striking male predominance, and it is hematology findings is somewhat similar to HBH disease. You can go to the ATR60, ATRX, other this table you have to be thorough with, so that if at all they ask differently about this alpha thalassemia intellectual disability syndrome, you can fetch your answer. Okay, so it is a striking male predominance. So coming to the question number 12 regarding high affinity hemoglobins, false statement. So again, next table in the Harrison, isolated erythrocytosis, not familial, no splenomegaly, no JAK V2, V617 of mention. That again easily you can rule out because it is not coming in the high affinity hemoglobins, you know. Okay, so again, high affinity hemoglobins, isolated erythrocytosis, it is often familial, no splenomegaly, no JAK2. Okay, so no splenomegaly. Again, this will give you a comparative or major findings in the HBC disease trait, HBC disease, HB trait, HB disease, etc. Again, unstable hemoglobins and hemoglobins, etc. Because this all because in this half an hour session I can't cover. It is not possible. So you have to read through these charts. So question number 13, drugs causing megaloblastic anemia due to cobalamin deficiency include all except cytosine, hydroxyurea, 6-MP, sulfasalazine. So again, the chart, drugs that interfere with the sense. So this is a causes of megaloblastic anemia chart, cobalamin deficiency, folic acid deficiency, antifolate drugs like methotrexate, other independent of either cobalamin and folic acid deficiency, refractory to cobalamin folate therapy. Some cases of AMLs and myelodysplasia can cause megaloblastic picture. Therapy used in those interfere with the synthesis of DNA, cytosine, arabinocyte, hydroxyurea, 6-MP, azidothymidine, orotic aciduria, thymine responsive megaloblastic anemia. So here it is sulfasalazine. Rest all causes megaloblastic anemia due to cobalamin deficiency. Again, coming to a different topic, paroxysmal cold hemoglobinuria, PCH. So question answers options include rare form of AHA with intravascular hemolysis, mostly in children, usually triggered by viral infection and usually self-limited. Donat-Landsteiner antibody and anti-I specificity, active supportive treatment, blood transfusion may be needed to control anemia. Usually the patient recovers. So about paroxysmal cold hemoglobinuria, this is again about PCH. So it's a rare form of AHA, mostly in children, triggered by viral infection, self-limited. So these points you have to, as a bulleted points, you have to remember, which I have highlighted in colors. It is the so-called Donat-Landsteiner antibody. It is a unique feature, that is, it's an anti-P sensitivity. So question showed anti-I sensitivity. So it is against anti-P, P antigen. Binds to red cell only at low temperature, optimally at 4, but when it shifts to 37-degree, lysis occurs. Okay, so in vivo there is intravascular hemolysis resulting in hemoglobinuria. Differentials include other causes of hemoglobinuria, but this antibody is the is vital in the diagnosis of PCH. Usually recovers. Okay, it might need a 1 or 2 blood transfusion, and depending on the severity. So false statement is C. So moving on, cold agglutinin disease. Which statement is wrong? So antibody produced by the B cell clone is IgM. Unlike AHA, there is no predominance of spleen, up to 60% response to rituximab. Unlike AHA, prednisolone splenectomy is very effective. So wrong statement we have to choose. So cold agglutinin disease, it's a chronic indolent condition. So there is an autoantibody which is reacts at the lower temperature. That's how it got its name. And hemolysis is prominent when the body is exposed to cold. Okay. Antibody is usually produced by a autoreactive B lymphocyte, usually IgM, no predominance of spleen. Okay. Avoidance of treatment. So treatment, avoidance of exposure to cold, plasma exchange to remove the antibodies, anti-CD20, 60% response, and fludarabine rituximab combinations. If CAD, there is associated CAD may be associated with lymphoproliferative disorders, lymphoplasmacytic lymphomas, or infections. Okay, so primary cold agglutinin is basically can be secondary to lymphoproliferation. In that scenarios, you have to give chemotherapy kind of regimen in plus or minus anti-CD20. And steroids and splenectomy is usually ineffective. So this is the wrong answer. And complement inhibitors has also been tried. So here, splenectomy and prednisolone. Splenectomy and prednisolone especially is effective in warm aging. Okay. Question number 16, monoclonal antibodies and small molecule in use in the development of management of PNH and complement. So this is basically matching the following. So the various combinations of targets and the drugs has been given. So you have to thorough with the drug. Again, there is a figure in the Harrison. Okay. So basically the classical alternative and the lectin pathway. So there is a downstream C4B and here it is the C3BB and C3 converters will convert C3 to C3B and there is an amplification loop. There is effectively in the terminally it will further C5 converters. C5 will be cleaved to C5B and C5A to form the membrane attack complex. Okay, so the blockade can be done at various levels, proximal, distal, and so there is anti-factor D is danicopan, anti-factor B is iptacopan. So basically it is a mix and match. So you have to be thorough so that you can exclude at least. Okay, anti-C3 pegcetacoplan. So pegcetacoplan, the advantage is it is more proximal than the C5 inhibitors. So the hemolysis secondary to opsonization will also be blocked by C3. Okay, so the common problems with complement inhibitors are there is increased risk of meningococcal infections and all because the complement mediated the killing of these bugs are gone. Okay, so anti-C5 is eculizumab, ravulizumab, crovalimab, and other these are the terminal inhibitors. Okay. So here anti-factor D. So you can see here danicopan is this thing. Okay, correct pair they have asked. The other things have been incorrectly matched. Okay. So question number 17, hypocellular marrow with pancytopenia include all of this. So again, straight from the this what you call it, Harrison. So myelofibrosis probably it's a wrong answer. So this is basically the straight from the Harrison chart. You can go through the other process, also pancytocellular marrow, pancytotic hypocellular marrow. Okay, so here the odd one out is myelofibrosis, not myelofibrosis, mycobacteria. Again, question number 18, pure red cell aplasia, false statement. Characterized by anemia, reticulopenia, absent or rare erythroid precursors in the marrow. In adults, PRC is acquired. Diamond Blackman anemia, congenital PRC is diagnosed at birth, early childhood, mutations in ribosomal proteins. And congenital PRC is often resistant to glucocorticoid treatment. So, false statement. So again, PRCA, as mentioned in the options, it is characterized by anemia, reticulocytopenia, and absent erythroid precursors. Usually in adults, it is acquired. So the treatment part, that's a correct answer. This is a false one. So they said it don't respond, but usually often responds to glucocorticoid treatment. Etiology, it is the mutation in the ribosome protein genes. Okay. Okay, D is the answer. Question number 19, again, Fanconi's anemia, false statement. Autosomal dominant, congenital developmental anomalies, progressive pancytopenia, and increased risk of malignancy. Chromosomes in Fanconi's are susceptible to DNA cross-linking agent. That's how you diagnose. Okay, diaperoxybutyne or mitomycin C. So, and peripheral lymphocytes. Typically short stature capsule anomalies involving the thumb radius and genitourinary tract. Most common is type A Fanconi's anemia due to mutation in the FANC-A. So basically, wrong is first one. Autosomal, it's not autosomal dominant, it's autosomal recessive. The rest of the things are the same. Short stature, capsule, anomalies in thumb radius and genitourinary tract. The 17 genetic defect, most common is type A. Okay, so basically, most these gene products form a protein complex activate the FANC-CD2 by monoubiquitination. Okay, which lead to cell DNA damage. They are more susceptible to DNA damage and intestine cross-linking. So it is autosomal recessive. Answer is A. And coming to question number 20, immune disorders associated with acute aplastic anemia includes eosinophil fasciitis, hypoimmunoglobulin, large lymphocytosis, all the above. So again, the chart. So this is here. immune diseases related, immune disease of fasciitis, hypoimmunoglobulinemia, arginine lymphocytosis, thymoma, graft versus host disease, etc. Okay. So other causes has been mentioned, acquired and inherited, secondary causes, radiation, drugs, viruses, etc. So this is a straight pick from the Harrison chart, all of the above. Easy question. Question 21, basically about thiamine responsive megaloblastic anemia. So there is a genetic defect in the high affinity thiamine transport SLC19A2 gene, causing a defective RNA ribosynthesis, embed activation transketolase, and maybe associated diabetic mellitus and deafness, presence of ringed sideroblasts in the marrow. So all the above. So probably this is also an easy question. Again, thiamine responsive, you have to remember the gene SLC19A2, defective ribosome synthesis, okay, defective impairment of a transketolase lead to decreased nucleic acid production, associated diabetes and deafness, ringed sideroblasts present. Okay. So question 21, it's again all the above. Question 22, regarding EPO replacement, false statement. Okay. The CKD usual dose of EPO is 50 to 150 unit per kg 3 times a week. Darbepoetin alpha is a long-lasting one, so half-life in circulation 3 to 4 times longer than the normal EPO. So it may permit weekly or every other week. So long-acting, okay, and orally available EPO mimetic or roxadustat, okay, and dose has been given. Increase the half-life of HIF, hypoxia-inducing factors. So that can increase hemoglobin. So what is the false statement? So here none of the above. So probably guesswork. It's easy to guess. Okay, so iron status must be valid. So if there is iron deficiency before giving EPO, you have to correct the iron status. Okay, then only EPO will work. And CKD usual dose is 50 to 150. HB 10 to 12 within 4 to 6 weeks if iron is adequate in more than 90%. Other problems, aluminum toxicity, especially in dialysis patient, hyperparathyroidism may compromise response. Infection intervene, it is best to interpret EPO therapy. Okay, you can transfuse that time. Dose of EPO, chemotherapy induced anemia is more, 300 units per kg 3 times a week, only 60% respond. So if we give overboard, like if you target HB more than say 12, it can lead to thromboembolic complication, have tumor progression. There are theories explaining this. And darbepoetin is a long-acting, 3 to 4 times longer half-life, and oral by EPO mimetics. Roxadustat, again the dosage is 50 mg thrice weekly. It increases the active hypoxemia-induced factor. So here it is none of the above. Question 23 is basically modulation of the fetal hemoglobin levels. Okay. BCL11A, MYB, locus linked to HBV cluster, notch, which of the except, okay. So option is, the answer is D. Modulation HBF with 3 levels. One is BCL11A, MYB6Q, and HBV cluster locus. And major variation, because depending upon the HB percentage, the outcome or phenotype of the various sickle cell and beta thalassemia can change, because HbF, hereditary persistence of fetal hemoglobin, dilutes the most of the sickling crisis in sickle cell anemia. So like that HbF. So basic idea of hydroxyurea and all HbF is basically to induce the HbF so that the fetal hemoglobin is more, so that there is some amount of dilution. Okay. And so here the odd one out is notch. Question 24, regarding antibodies in pernicious anemia, again an important topic, which is true. Intrinsic factor is blocking or type 1 antibody prevents the attachment of IF to ileal mucosa. IF binding or type 2 antibody prevents combination of IF and cobalamin. IF antibodies detecting gastric juice up to 20% of PA patients. Parietal cell antibody presence of 90% adult patients with PA, but frequently present in other subjects. So pernicious anemia antibodies. There are two types, blocking and binding, type 1, type 2. Type 1 occurs in 50% patients, type 2 in 35%. If antibodies crosses placenta and may cause temporary IF deficiency in newborn infants, cell-mediated immunity to IF. Type 1 is detected rarely in serums with the PA without PA in cytotoxicosis mixed in other autoimmune conditions, you can get type 1. Okay. Or even in relatives of PA patients. And IF and antibodies can also be detected in gastric juice up to 80% of the PA. So that is the odd one. The option was given 20%. Okay. These antibodies may reduce the absorption of dietary cobalamin. So parietal cell up to almost 90% adult patient can occur in other subjects also. It occurs in as many as 16% of randomly selected female subjects more than 60. Okay. Parietal antibody directed against the alpha and beta subunit of the gastric proton pump proton. So here it is the option D. Okay. It is the true statement. Okay. Other things are wrong. So last question, 25th question, drug that carry definite risk of clinical hemolysis in G6 period. So last year this was asked, okay, in a kind of a different manner. So there is basically the drugs causing definite hemolysis in G6 period deficiency straight from the Harrison chart. So definite risk, possible risk, doubtful risk. So definite risk, so this chart, if you can remember, it seems to be a favorite question. So combinations can be asked. You can remember it's some code or some, so you can make your own kind of a way to remember these drugs. Okay. So here the drug is nitrofurantoin. Okay. Definite risk of hemolysis here, nitrofurantoin. Okay. So thank you. This is the module 1. Okay. So children, please, students, you please go through the Harrison charts and table, especially the charts and tables videos in the tutorials app or the this quick revision points. Most of them include the Harrison tables and charts. So so last moment revision, you don't forget this. Okay. Thank you so much.